focusing on GI, about the H&E microscopic growth pattern of the metastatic colorectal carcinoma in the liver. And actually, there are two parts of this morphology finding. One is focused on the carcinoma in the liver, and the other part is for the rest of the liver. There are any let's try to have a laser. Yes, focus on non-neoplastic liver, including like cholestasis or other like lymphocytic infiltration finding, and all of these two relationships with the prognosis and the survival. And then the original article is based on this new one, but this new one, all of these microscopic feature is borrowed from this article 2017. So briefly introduction, everybody really familiar with that is the colorectal carcinoma is the third common cancer in men and the second most common in the woman. And a lot of things we already would like to use to predict the prognosis, including the primary carcinoma morphology and immunohistochemistry staining, and also molecular parameter, and also a lot of undergoing research to find some new biomarker to predict the prognosis. But so far, it seems just the tumor stage is still the most important prognostic factor we will consider. And then distant metastasis is also the most important factor, as like all the other cancer we have known. Then around 50% of the colorectal carcinoma, when they find the diagnosis, we have 50% already have the liver metastasis. So based on this finding, this group would like to see whether any metastatic growth pattern of this metastatic carcinoma can have some predictive for the prognosis, and as well as the non-neoplastic liver finding related to any growth pattern or the survival. So the goal is really simple, just analysis of the metastatic tumor in the liver, and also the non-neoplastic liver finding, and then correlate these two with the survival. And then they have the material review from 2011 and 2020. And then there are two exclusion standard from this study. One of the, if they could not evaluate of the slide, they excluded that patient, and also radio frequency ablation before the surgery and any other neoadjuvant, because I think if the patient get this kind of treatment before surgery, the desmoplastic stroma is really hard to predict, because we know the tumor bed will be there, so it's really difficult to find. So that's the reason they exclude this tool of therapy before the surgery. Then they mentioned all the morphology standard is borrowed from this article 2017. And then the non-neoplastic liver finding, they just divided into steatosis, cholestasis, and ductal reaction, as well as the lymphocytic infiltration. So from this 2017 article, they divide this morphology finding of the metastatic carcinoma in the liver into these 5 groups. And from this study, there are more patients included in this study, so they still use these 2 groups. One is the sinusoidal growth pattern and the portal. But from the current study, it seems they do not have so many patients. And then these 2 growth pattern is really rare. So they decide to just focus on these 3 groups, and then they can include more patients in this study. So So let's get bigger of these three groups, how they can define this standard, how to determine. I think this morphology feature is really easy to identify. The first one, whether you can see desmoplastic stroma rimming around the metastatic carcinoma. If yes, the patient will go to desmoplastic growth pattern group. And then if no, they, including this concept, just like the carcinoma cell with the normal liver parenchyma, do they have kind of a little bit infiltrated growth, like perpendicular? I think this concept is more similar to the tumor budding when we evaluate for the colorectal carcinoma in our cyanotic report. And then if no, they will put into the last group, that is the pushing border. That means no desmoplastic stroma and then no infiltration, just like the well-forming gland just pushing all of the parenchyma of the normal liver. So let's see the HNG finding of this group. So the first group is desmoplastic growth pattern, very straightforward. We can see low power, a lot of this nodule of the tumor, and then we can see this pain area, our desmoplastic stroma, and then this is normal liver parenchyma. So this is clearly defined as a desmoplastic growth pattern. A little bit higher power, we can see this pale desmoplastic stroma around this metastatic tumor, no different area. Even higher power, desmoplastic stroma, really clear here. Again, also higher power. And then we also, they also noticed that whenever they find this desmoplastic growth pattern, often I think they mentioned like around 70% they will find this peritumoral lymphocyte infiltration. And then they also find some reactive pattern of this ductal proliferation between the normal liver parenchyma and the tumor. They can find more this reactive, and also the lymphocytes. And then another important feature is that whenever they find this desmoplastic growth pattern, they will find some portal tract do not destroyed by this stroma. So this stroma just hugging this relatively normal portal tract area, not just destroy it. And then whatever the primary tumor, even they show this mucinous feature, they still show this desmoplastic stroma between the tumor and normal liver parenchyma. And then another pattern is the replacement. From my understanding, it's more like a little bit infiltration, because clearly in this low power, we can see this pale area of the desmoplastic stroma. And still, in this low power, maybe we can still draw a line relatively demarcated between the tumor and the normal liver parenchyma. But high power, we can see this kind of cell have this like budding hyperchromasia cell just perpendicularly growth into the normal liver parenchyma. So there is some of the normal liver cell here, but they already intermingle with this kind of infiltration growth of the tumor cell. More picture of this replacement. We can see this clearly colorectal carcinoma, and then maybe this is normal liver. Then the last growth pattern is the pushing growth pattern. So we can see the glands kind of well forming, and then we can draw a clear line between the normal liver and the metastatic carcinoma. Higher power, we do not see the kind of infiltration, and then the tumor budding just perpendicular go into the liver parenchyma here. So they call this pushing growth pattern. More picture to show this pushing. the gland still not parenchymal growth into the normal parenchyma, and then no desmoplastic stroma. So for these three growth patterns, we can see the replacement growth and desmoplastic growth. There are more cases fall into these two categories. And then when they do the statistic, they can find this peritumoral lymphocytic infiltration. They have much higher percentage in the desmoplastic growth pattern compared to, especially compared to the replacement. And then also this ductal reaction. Other than these two, they follow a lot of other parameters, but no significant difference, including CA level and also other like the normal lymphoparenchymal changes, no significant difference. Then the analysis of the survival. Here they show the survival rate from the desmoplastic growth pattern is 47%, compared to the pushing is 37, and then the replacement growth is 17% of the survival rate. And then in this survival analysis, I think because of they have limited number from each category, so their p-value is not really good, but still significant, at least from their calculation. And then when they take the pushing border growth pattern out, they have better, the better p-value, 0.011, and then they can show that desmoplastic have better survival compared to the replacement growth pattern. Then again, to go back to the conclusion of this study, this straightforward study, they focus on these three growth patterns. Then because the limited number of the pushing growth pattern, so they more focus on these two, compare these two H&E finding. Then they find desmoplastic, they have better survival compared to the replacement growth pattern. And then some other study also had a similar finding. Some people may also compare these two growth patterns as a non-desmoplastic growth pattern. And then when they compare this group and these two groups together, still have the similar finding of the survival. And other study also show even in melanoma, including uveal and the skin cutaneous melanoma and the breast carcinoma, the growth pattern in the liver also had similar finding with the colorectal carcinoma. And then from this 2017 study, they include more patients, and then they would like to see whether the cutoff, this main growth pattern, matter. Does it change any inclusion? It seems it does not matter at all. Even you just use 50% cutoff of this main growth pattern, their survival curve didn't change at all. I mean, the p-value. Even you used 100% to divide into these two groups, of course, we will have less patients included, but the conclusion didn't change. So, and then the discussion about this study is the 5-year survival in the metastatic colorectal carcinoma ranged 46% to 58%. And then 5-year survival rate if you use desmoplastic metastatic growth pattern and the non-desmoplastic, the desmoplastic is 63.4% compared to around 46% in the non-desmoplastic growth pattern. And then from this study, we also know if we have more lymphocyte infiltration, it is more related to the desmoplastic growth pattern. And then another study also just highlight this memory T helper cell. They have positive effect in the total survival. So it totally makes sense. And then also another study also study about this peridactyl reaction. So it seems like these two reaction pattern also related to better survival, especially in the desmoplastic.
Natural Keytruda, right?
Sorry?
Is that what we're saying? Your immune system is more revved up and aware of it too.
Yeah. So in the conclusion is that because this is really easy finding in our pathology report, they just would like to, is it possible to just give this brief description when in our reporter's line, what kind of pattern, and then the clinician will know better or worse prognosis.